just as a quick reminder, just in case you're in the wrong group, this meeting today is to talk about the SOAP study results, to see the analysis, to hear about the analysis of the efficacy of the vaccine studies in MDS patients. And if those of you who haven't finished the poll could just carry on, that would be fantastic. Again, that information in the poll will help us greatly to inform NHS England about the status of third vaccines in the country. We will feed that back on our next meeting with them. We have monthly meeting with NHS England, with all the other blood cancer charities, with all the other cancer charities, and they rely on that information to feed back to relevant people. Okay, can I see Austin? Let me find Austin.
I'm on there, so can you hear me?
You're on there. I can hear you, Austin. Okay, so let me just make a quick introduction so that Mariana, who's on the call, can also record. So thank you very much, everybody, for joining us today, 14th of October, to have a presentation about the SOAP study results regarding the efficacy of the COVID vaccines for a cohort of MDS patients. And we have great pleasure to have Dr. Austin Kulasekararaj from King's College Hospital here to present the data, some of the very preliminary data on this important SOAP study. As a reminder, the SOAP study has got a MDS subgroup, but it's a much wider group of people that were tested for efficacy of the vaccines so far. So we have Austin has got some slides. And I will ask you to maybe take us through your presentation, and we'll then go through with questions, if that's all right with you, Austin?
Yeah, no, that's fine. Yeah, thanks, Sophie. Can you see my first slide, because it's behaving a bit funny?
It is.
Okay, fine.
I can see it. If everybody else can see it, give us a thumbs up.
Yeah, good.
Yeah.
Okay, perfect. Firstly, thank you. And the second is apologies. This has taken quite a bit of time to get it back to the community, as due to a number of different issues, but I won't delve into it. Thirdly, and more importantly, thank you for number of people on this call who volunteered to be part of it. This is your data, your samples. I'm presenting on your behalf. There are a number of people who wanted to do it, can't do it. And so this is your data. Lastly, I just want to say quite a lot of this is scientific, but I will try to uncouple whenever the words and other things are quite difficult. But please ignore loads of things which are written on there. They're very scientific. Some of them even go above my head as well. So I am in the same ballpark as you. If you don't understand, I don't understand as well. So just wanted to briefly. So this was presented to the Blood Cancer UK group consortium yesterday, and Sophie was there and presented by colleague Dr. P.S. Patton. So I'm only one part of it. There are a number of people working on the study, and as Sophie mentioned, SOAP was initially designed to test how people responded to COVID infection back at the time when we had the first lockdown in March 2020, predominantly in patients with solid cancers, i.e. breast cancers and other cancers, and also other kinds of blood cancers. And then subsequently, the study evolved so that patients who had vaccines were assessed to see if they respond to the COVID vaccinations or do not respond to the COVID vaccination. And what I'm presenting today is, as Sophie said, a preliminary data on the first few patients who have been on the study. So yeah. So hope you can see my next slide. So this is the population which was looked at was around was exactly 38 patients. So, and 16 patients received the Pfizer vaccination. So anything which starts with a B, that's a Pfizer vaccine. The 22, which has got the Ox bit in it, is the Oxford vaccine. So 16 patients had received the Pfizer vaccine, 22 patients have received the Oxford vaccine. We, for a couple of patients, if they've had a previous viral and COVID infection, we had to exclude them. I'll tell you why. And the good thing is we tested the blood sample approximately 3 weeks after the second dose of the vaccine. So you can look here, all MDS patients, there were 38 MDS patients. The median age of this patient group was 67.5, with a range between 40 to 82 or 83. This is what we call it as the middle range, the 25 to 75% of people. 2/3 of patients were male and the third were female. And that's not unusual because, as you probably know, MDS is a bit more common in men than in women. With some predominantly Caucasian white ethnic background, some BAME population. So from the time of the first vaccine, i.e. first dose to the second dose, was 75 days. That's an average. So that's what the NHS England were telling us at that time, and the JCVI saying it should be at least 10 weeks or 12 weeks. So if you could see my cursor, can you?
Move it again.
Yeah, can you? No? Can you see it now?
Yes, yes, yes.
Okay, sorry, I was doing it the wrong way. So the median time from the first dose to the second dose was around 75 days, which is what, like 10, 11 weeks. And the median time from the second dose to doing a blood test was 19 days. And this is the group of MDS patients. So there was a group, quite a few patients, predominantly low risk MDS, yeah, as indicated here, and some high risk MDS. And nearly 60% of patients were only on transfusion support or watch and wait. Some patients were on GCSF, EPO, or L-Trombopag. 3 patients were on cyclosporin. 5 patients were on 5-azacitidine. And there were some other patients who were on other combination as well. And as you could see, there is a mix of patients. This is the Pfizer, and this is the Oxford vaccine, 16 and 22 we talked about. There was not much difference between the groups of patients in either the type of their MDS or the treatments they've received or their age or anything else. So it seems to be equally distributed. So just one caveat I just wanted to let you know is the healthy volunteers, which are 26, which are predominantly laboratory people. So they will definitely have a lower median age. So they were 36, 36 years of age, and male and female distribution with a mix of people as well, and a similar type as well. So obviously they don't have MDS, so you can't see. The one important thing we need to differentiate here is all the healthy volunteers only received Pfizer. They did not receive Oxford vaccine. So that's the background of these patients. So this is again, I don't want to get it confused. So here we are looking at the antibody response. Yeah. So this is healthy volunteer. This is patients getting the Oxford vaccine. This is people getting the Pfizer vaccine. And to look at healthy volunteers, most, if not everybody, had above this cutoff. Yeah. This is negative. Yeah. This is positive. So all of them had antibody responses against the spike protein. We call it S protein or spike protein. All of the healthy volunteers had a response, which is not surprising. In MDS patients, you could see in the Oxford vaccine group, there were 5 patients who did not show a response in the antibody levels, while the Pfizer patient showed response. And the amount of response was also slightly different between Oxford and Pfizer, i.e. you have a better chance of antibody responses when you get the Pfizer rather than the Oxford vaccine. Yeah. And this is a slightly complicated one, but I think you might be able to understand. So this is to say, oh, you produced antibodies now. Yeah. And when you put these antibodies against this COVID virus. This is Wuhan virus. This is the Kent variant. And this is the Indian variant. So I'm not supposed to say that, but it's Delta variant, Alpha variant, and the wild type. Yeah. So the first strain, and then the strain which came from the southeast, and then this is detected first in India. So it's called wild type, Alpha, and Delta. So to see whether when you have the antibodies in patients with MDS, either patients who got Oxford or the Pfizer, whether you are able to inhibit or neutralize the response, i.e., can this antibody be effective against the virus? So this is what I was keeping on telling last time as well. Some of the commercial antibodies, you will be able to measure this, but here nobody will be able to check whether the response is able to neutralize the virus. Yeah, be it a Wuhan strain or the Kent strain or the Indian variant. So here it shows that yes, there are a significant proportion of patients are able to neutralize against wild type, Alpha, and Delta. There were some patients who were not able to neutralize against the virus as well. So they were producing antibodies. Yeah. So there were some patients who were not producing antibodies. And then in patients who were producing antibodies, there were some patients here indicated in this colored ones, where these patients were not able to, although they had antibodies, they were unable to mount a response against either a wild type or an Alpha or a Delta, more prominently seen around the Delta. Yeah, so that's what that slide shows as well. Yeah. Then in the next data, if you look at it, so this is trying to do a plot against if you have the antibody and if you are able to neutralize. Anybody who falls in this upper quadrant, in this graph, here, means that they have a good protection, both antibody and ability to neutralize. Yeah. So if you have a high antibody, then it means that you're able to neutralize against the virus. Here, looking at so now we are looking at T cells. Till now we were looking at the B cells, i.e. antibody producing cells, yeah, which is what sometimes is commercially available and which is what the government is going to do using the finger prick test, to looking at the S antibody or spike antibody response against the vaccine. Here we are looking at T cell responses, i.e. to see whether your T cells, which is another element of the immune system, will respond against the vaccination. So here you look at the MDS patients against the wild type, Alpha, Delta, and this is against a control. So ignore that bit. But again, showing that in patients with MDS, you are able to mount a T cell response in a significant proportion of patients against the wild type, which seems to be similar to the healthy volunteers, and same with Alpha, Delta as well. There are going to be few patients who are not able to mount antibody responses, these red dot, which are on T cell responses, which are on the bottom. So T cell responses against the Delta variant was slightly reduced, as you can see that in healthy volunteers, 20 out of 21 of them got it, but in MDS, 12 out of 17 who got the Oxford, 10 out of 14 who got the Pfizer vaccine. So these 5 patients unfortunately did not have a response, and these 4 patients who did not have a response against the Delta variant. So this is another graphical way of summarizing. So apologies, I don't want to make it complicated, but essentially to say which patients have got antibody responses, which patients have got responses against the T cells. Yeah. And if you look at it in healthy volunteers, nearly 95% of patients will have both antibody response and T cell response. While in MDS cohort, close to 56% of patients will have both the responses. Some patients will have antibody responses, but will not have the T cell responses. The other patients will have T cell responses, but won't have the antibody responses. while in Pfizer, it is up to 66.7% of patients will have a response to both antibodies and also to the T cell response. So compared to healthy volunteers, when you have 95% of healthy volunteers having both antibody and T cell responses, in the context of MDS, in the context of Oxford vaccine, both responses are seen up to 60% in Oxford and 67% in Pfizer. But when you look at single responses in MDS patients, up to 86% of patients will have responses against the spike protein, with T cell responses seen in 82% of patients, slightly less against the Delta variant at 70%. But if you put it all together, that's what the data shows. Yeah. So the best possible is best case scenario is 60% of patients with MDS, either if they get AstraZeneca or Pfizer, will have a total protection with antibody, T cell responses, and also against the newest Delta variant. So that's the best case. Up to 60% of patients will have it. So lastly, these are the conclusions. So number one, so thankfully, it's not like some of the other cancers or other hematological conditions like CLL or chronic lymphocytic leukemia. MDS patients are able to mount a response to both vaccines. It is definitely weaker compared to healthy volunteers. Possibly there is a slightly lower response in the Oxford compared to Pfizer, but it's not conclusively proven. And one of the good things I would take out from this is, although there were 5 patients who did not have antibody responses, they were able to mount T cell responses. So in one way or the other, there is a protection offered against reducing the risk of complications associated with COVID. Yeah, and quite expectedly, this has been shown in other cancers. Against the Delta variant, there seems to be a reduction. So what are the practical implications of this is that definitely I think booster vaccines or third primary should be given for MDS patients, but also since it's not 100% effective, we should also be extremely cautious and try to be very pragmatic and very practical about avoiding exposure, big group of people, and other things. So there is quite a lot of good news in the sense that it all depends upon how people take it. If we look at it in an optimistic way, up to 60%, 65% of patients with MDS will show a good response to COVID vaccination. Yeah, but if you look at it the other way, you can say 40% don't have either one or the other response. Yeah, but you need to be extremely careful. And the only thing which is going to happen is with the boosting and the third primary, there is a likelihood that patients will have increased response, and the response could last for a longer period of time, because there is some data showing that vaccines response could decline over a period of time. And thankfully, and again, thanks to all the patients and other people who contributed to this, we are able to continue to monitor this group of patients prior to their third vaccine or booster and post their third vaccine and booster. So I think I'll probably stop there, Sophie, and happy to take questions.
Thank you so much, Austin. That is great. I think that helped me greatly compared to the presentation last night as well. That was indeed quite highbrow. The question I asked you last night was also amongst the people who did not respond. So are there any commonalities? And you kindly explained that there weren't. Do you want to expand a little bit on that?
Yeah, so what Sophie's question is, can we identify a group of patients if they have a common characteristics to see will they fall into a group? Say, for example, or they people over the age of 70 or people over the age of 80, or do they have a particular subtype of MDS, or are they on a particular type of treatment for their MDS? And although the caveat is it's only 38 patients, but there doesn't seem to be a particular group of patients who do not respond to the vaccination. So it seems to be a mix and match of different group of patients as well. And also you might think, oh, I've got high risk MDS, I'm on azacitidine, will I respond? So there were quite a lot of patients. There were patients who had azacitidine who responded, and there were a couple of patients who had azacitidine who did not respond to the antibody as well. So it's difficult to identify a particular group of patient as being responding to a particular vaccine. The one more thing, Sophie, if I may add, is none of the patients in this group had a transplant for their MDS. So I know there are a number of people on the line who would have had transplants. So this is not apply for patients who are transplant. Transplant data is coming. There is a couple of studies which are ongoing, and that will help to delineate it as well.
Yeah, absolutely. So I expect that Anthony Nolan will be doing something similar. I know Hugues de la Valade presented yesterday, and in the cohort of transplant patients, there were a handful of MDS patients and a handful of AML patients. So, but that it will be dealt with separately. So, well, we had some questions indeed according to transplant, but that we'll leave that for another session, because we'll concentrate on MDS. So you've already said there were no patterns according to subtypes or mutations. We had a question on overlap syndromes as well. So whether MDS/MPN was any different, or obviously watch and wait compared to people who do not have treatment as such. So you've answered there is no particular pattern as of now. Will there be more analysis done to dig further into this, or
probably not, because what happens is we are restricted with the numbers issue, is it? So I think if you need to go into each individual subgroups of patients, then we need at least 300, 400 odd patients to delineate between, because we are also restricted because some patients had Pfizer, some patients had AstraZeneca, which is good in some ways because we can compare and contrast, but to whittle down to numbers, it will go down to smaller group, and then we will not be able to separate out. We will introduce artificial bias into those kind of analysis, and we don't want to do that.
Yeah, in comparison, just to give people an idea, the myeloma cohort, I think, which Karthik presented, was 214 myeloma patients, splitting myeloma and then smoldering myeloma, and they were able to have smaller subgroups, of course. We're not so lucky with the MDS to be able to do that. Okay, we had other questions also, whether the white blood cell count or neutrophil count matters in terms of level of protection from
no, I think again we did look at it, and I don't think so there was a particular correlation to the level of white cells, level of neutrophils, or any other blood parameter which could have had an impact. Again, I'll keep saying this for every question, I think so, but just as a word of caution, because the number of patients is small, so it is very difficult to be totally certain whether they would have a role to play in changing the response or not. And I know there are some questions about hypocellular MDS, and there were quite a few patients with hypoplastic MDS or hypocellular MDS with overlapping with aplastic anemia, and there was no difference in those group of cohorts as well.
Thank you. And just to confirm, there were no differences in patients who had azacitidine or not. You've already answered that, nor any other form of chemotherapy.
No.
Okay.
No. We did not have anybody with intensive chemotherapy or transplant, but azacitidine, I think if I remember rightly, we had 5 patients on 5 azacitidine actively on treatment.
Okay, thank you. Now, we also had questions generally about what you expect the third booster, the third vaccine or the booster to do following these results.
Yeah, so I think these things tell us something. Is that the level of protection or the antibody levels, quite not surprisingly, is less or lower than a healthy volunteer. So definitely boosting or giving the third dose is the right thing to my understanding. The third booster is the third primary dose in the JCVI website is slightly written in a unusual way, but it's up to interpretation. I personally think most patients with MDS should have a third primary dose and not wait for the booster, i.e. leave 6 months. I think there has been now good studies showing mixing of vaccines as well, which is called heterologous studies or vaccine studies. So that is why I think mixing vaccines might be a good thing. And if I'm not wrong, I need to look up on the literature, but I think the booster, people are predominantly getting Pfizer, if my understanding is right, or half dose of Moderna vaccine. So I think it'll be good, but I think we need to wait for the final recommendations as well.
Yeah, that was my next question. Should patients wait a little bit and see what the JCVI will definitely decide? And should we request a different type of vaccine to the one people had for the first and second vaccine?
Yeah, so that's a difficult question, because I personally like what we talked yesterday. Whatever vaccine is offered, I would go for it. Would they call it booster or would they call it third primary? I think the messaging has not been that great, but I think I would suggest that as a community, if there is no other contraindications, I would suggest we should all go for the third vaccine. It's semantics, I think so. To my knowledge, what they call it third primary or booster. I understand some people will have difficulty because booster is technically given 6 months after the second dose. Third primary can be given 8 weeks after the second dose. So if you fall in that gap, your GP or treatment team might say you're not yet eligible. But I think I would suggest that whatever is offered, we would need to get it, because it seems to boost the responses and keep it going for a period of time.
Okay, and I assume that the JCVI will take account of the SOAP results for MDS specifically in their decision, because we saw that myeloma has got a much better response rate, I believe, to the vaccines. So the recommendations might differ quite a lot.
Do you want me to take some of the questions from the chat as well?
Sorry, I don't know if you heard that one. Will the JCVI take into account the SOAP results specifically, considering that MDS is quite different from myeloma, for example?
I don't know. Obviously I don't have the authority or the power to influence them, but at least if the messaging from the Blood Cancer UK through this data is strong, they might be able to personalize and individualized based on different diseases. Unfortunately, they've got thousands of diseases to deal with. So I'm hoping there will be some response to this data, but maybe through the Blood Cancer UK, I think so.
Okay, thank you very much. Now, if we turn to some of the questions that appeared in the chat, you are able to look at it with me. I've not kept an eye on.
No, I've looked at it. I've sort of answered some of the questions as well. So we did talk, Caroline, we did talk about hypocellular MDS and hypocellular. So we did have 6 patients who were more hypocellular and there was no difference in the response. Will this data be used to guide transplant decisions? Probably not yet, I think so, Paresh. So we need to see. And Maria asked about transplant. Do you have any data on response to vaccine after transplant? No, SOAP study did not actively excluded patients who had transplant in this, but there are other studies ongoing which will look at it. I think Lee had asked a separate question. If a patient had COVID, they were removed from the study. Yes, I think so, unfortunately, because what happens is when you have COVID, you have a particular type of antibody called N antibody or nucleocapsid antibody. So in patients, even if they didn't know they had COVID, we would be able to find out if they had COVID based on that antibody. So I think there were 1 or 2 patients who had previous COVID and we had to exclude from the analysis because it will interfere. I think we answered Chris's question on correlation with white count and other things. We did talk about Tony's question as well, mix and matching, which is a good idea, but I wouldn't delay it. I would just go and get whatever is offered. Kirsty is asking about any research to see if the vaccine might trigger MDS. Interesting question. I've not come across, I've not heard anything from the international community as well. But since millions and millions of people are vaccinated, there will always be some anecdotal link between vaccine and MDS. Can we prove it? Can we not prove it? It's a difficult thing. Yeah. So as a trigger. Is there an individual test at some point? Yes, because I think Sophie did put it in either in the chat or in the MDS form thing. Do you want to expand on that, Sophie?
You're referring to the national antibody trial test. So the government has started a trial test for 10,000 people with different cancers or vulnerable people. Now, that is phase 1 of this project. They may expand to a phase 2 because we highlighted that the patients on watch and wait or on transfusions or any supportive care were not included in that particular project. They had only opened it to people who were on, quote, anti-cancer treatment or some form of chemotherapy. So they may have a phase 2, but again, we have urged them to wait to see what the SOAP results will reveal, to see if antibodies alone is worth checking, or whether it needs to be done in parallel with a T-cell response. But it is on our website. You can still register. And you could be amongst the 10,000 people there will be testing so far. And I think some people on the call today have registered already.
Yeah. So if I continue on that, so I think Mike had asked that. So Donna, usually third primary and booster is, I don't think so it's very clear, but they've said 6 months. So if you use the same example as second dose and booster, it's separated by 6 months. So I'm assuming the third primary and the booster hopefully would be separated by at least 6 months, unless newer data comes and there is a difference to it. I think Joanne is asking particular questions around SOAP study. So the intention is initially when you all kindly signed up to the study, the MDS patients, the intention was to do it 2 weeks after the second vaccine, 6 months and a year. But because of the third dose, i.e. third primary or booster, the plan is, if it's possible, we want to do a sample prior to the third dose, and then 2 weeks to 3 weeks post the third dose. So 2 samples around the booster or third primary.
Fantastic. That was my question as well, to see, because you had talked about expanding to include the third vaccines. So that's very good. Okay, I can see that a couple of people had their hands up as well, so I might take a couple of questions, bearing in mind that it is also 5:45, and I don't want to abuse of your time, Austin. So, Jamie, you had your hand up.
Yeah, thank you. Hi, Austin. So it's just a quick question just on the SOAP study. So I've had my third booster vaccine, call it what you will, and it was same as the primary dose of Pfizer as well. And just wonder if that now obviously has an effect on the study, because I took part in the SOAP study as well.
Yeah, so I don't think so. Thanks, Jamie, for that. I don't think so it should affect, because every data is important, because we are all learning and we understand that the number of samples, number of vaccines is a number of patients in this trial is small, but technically we can't. I don't think so. We can have a warfare with myeloma people, because myeloma is obviously a bit more common than MDS, and so I think we would probably be useful if you're able to continue on that, to continue to provide samples as well. And similarly, I think Lee asked in the chat as well whether if you've had COVID part of the COVID study, would it be worthwhile continuing? Yes, I think so, because then we can see, because these are all unique opportunities to understand what happens to the antibody response. Because I think I mentioned this to you before, I think so. Whenever a patient gets a natural infection, their antibody levels are high. And then when you boost it with the vaccine response usually goes 3 to 4-fold higher than somebody who's never had COVID and just had vaccine. So natural immunity is always better, but not that we want to willfully get natural immunity through that, I think so. So it is important.
So could I just ask one more, just to follow up on when you're likely to start those additional samples?
I will make sure they've contacted, because they were frantically trying to contact people towards the fag end of last week. But I will make sure I will remind the team to contact, I think so, to make sure everybody who has participated gets a reminder email or a phone call just to invite on an appropriate date.
Yeah, because I think it's like 3 weeks since my last the vaccine, so just sort of concerned getting outside of that kind of.
I know. Yeah. I wish I could drag you today, Jamie, and do it myself. I think so, but I can't. Yeah, I'll make sure.
Yeah, thank you.
As a follow up on that, Austin, are there any plans to include new MDS patient that you could test for the third vaccine, or is that not worth doing?
Probably not. I think it needs to go through a number of loops and hoops as well. And I think, unfortunately, although I totally love doing these kind of things, it's just the time and energy and the restriction and the money type of restrictions which everybody has got. So we just need to make sure we do it properly on the data we've got, rather than including newer patients. And I'm hoping because this is a global problem, and I'm hoping there are other interested groups all around the world who are collecting more MDS data, more vaccine data, so that as a community we learn together.
Yeah, certainly we'll be also reaching out to our international advocates everywhere, and the centers of excellence everywhere, to see what they're doing. Catherine had her hand up as well, and just if you have a quick question, Catherine.
Yes, I do. I just wondered, I have heard that if your first 2 primary doses are AstraZeneca, that your third primary dose should be the Pfizer one. Is there anything in that, or is it just kind of, it doesn't matter which one?
I think my understanding, Catherine, is also the same, that the booster dose is Pfizer or half dose of Moderna, irrespective of whatever the patients have had in the past. That's my understanding, but I just need to. These things change every day, so it's so difficult to keep track. Not literally every day, but they do change. So I don't want to give a wrong information.
So I haven't had any contact. I did speak to my local haematologist, Dr. Ruffley, and she said that the GP will do it, but I don't know whether I should contact the GP or what I should do, to be honest, about getting my my third primary.
So maybe should I just jump in there, Austin, as well, because we on the call yesterday, Peter Johnson of NHS England said that the notification letters for people are going out today, yesterday and today. So there were some delays and a lot of confusion, as reported by all the other cancer charities. But the letters should be going out. Certainly you should be getting something by the weekend or Monday to help you then talk to your GP to see when they can do the vaccination, or whether they'll point you to a mass vaccination centre as opposed to the GP, because as you know, the GPs are stretched beyond anything. I don't know if you have more information, Austin.
No, I think it's always the case is that it's always could be done in a better way, but it never happens because of a rush in doing all these things. So there are two port of calls. One is through your GP and other is to your hospital team. We do have template letters, but it's like anything, even here in King's, we had significant delays in sending those letters out, and we are only slowly in the process of sending those letters out as well. So apologies for all those delays. Yeah.
Thank you very much. Yeah, sorry.
You're welcome, Catherine. Yeah, and also there is confusion amongst GP practices as well, because they themselves had not received notification from NHS England or Public Health England to say that they can start or should start the vaccine procedure. And then we also heard from GP practices that had no stock of the vaccine, so couldn't, even if they wanted to, offer the vaccines yet. So it's going to happen in drips and drabs still. I think we've gathered some feedback from various people already. That's also why we ran the little poll at the beginning, to get a better picture of the situation, and to feed that back to the NHS England team so that they have a better picture.
Thank you. Just very briefly, I have had a letter from St Thomas's and Guy's inviting me up there to get it, and that was a few weeks ago, but I can't get up there, so I have had that. So anyway, I'll do what you've asked. I won't keep you any longer. Thank you very much for the advice.
No, lovely to see you, Catherine. Thank you.
Thank you.
Chris Dugmore is just putting something in the chat as well, the advice from the JCVI. So what we will do is we'll obviously follow up on whatever happens. I believe the JCVI hasn't decided fully, or hasn't revised everything just yet. And again, they may revise their recommendation yet again following the SOAP study results. So we need to wait a little bit on that.
So, Sophie, one thing is that, as Chris has put in the chat, with the booster vaccine, they are definitely recommending either Pfizer or half dose Moderna. Yeah, so that is sort of clear, I think so. But what they've not been very clear is about what should people get as a third primary. I don't think so. They've clearly said what the vaccine should be for a third primary. So the booster, yeah.
Austin, that was from the what I've copied. It was from the JCVI guidance on the 1st of September about immunosuppressed, and that I've just cut and pasted that from the JCVI 1st of September, which is referred to in their 30th of September guidance to NHS trusts and GPs. So that is definitely what they were saying about the third dose. They also say it in their booster information as well. So
okay,
whether they've changed it, I don't know, but that was the latest guidance that they referred to.
Okay, thanks, Chris, for the clarification. I think the head is getting very muddled with all these too many informations and just can't. Yeah. So let's see.
Okay. Right, we're coming to an end. If there are no more particular questions, I can't see any hands up, I can't see anything in the chat. I haven't got any more. Oh, there's one more message appeared. From Suzanne. I was reading on Blood Cancer UK that for the third primary dose, do not accept the half Moderna dose. Okay. Again, yeah. I think we'll need to. I'm hoping, based on what we've seen from the SOAP results, I think some things probably do need to be revised to be specific to MDS. So I hope that they can take that into account.
Yeah, but just Sophie, to sum it up, I think it's because we were all very concerned: is the vaccine going to give 10%? 1 in 10 patients will respond. 2 in 10 patients. So it is in some way promising that a higher proportion of patients are showing response to the vaccination, but still not 100%. Yeah, it will never be 100%, but we need to be extremely careful and cautious about the other things as well. So we just need to make sure that we adhere to some of the guidelines and other things and be careful, I think. So yeah,
the main recommendation was definitely that you should adhere to the usual protection steps, and not to shield to some degree, be extra cautious, and that certainly is very important for all the people who are in working age or unemployed and so on, because it is very important to have that protection, to have that support. Okay, wonderful. I have, for those of you who want to see also what the poll said, very quickly, most people, well, there's 2 people who've not been offered a second vaccine, so that's a bit worrying. But most people saw that the vaccine might not be effective, and they read that via charities and support groups. Okay. 11 out of you had their third vaccine, another 5 had the booster, another 3 have got an appointment, but 16 have received nothing. And do you know your most people don't know their response, neither due to antibodies nor to T cells, and half and half have already responded to the national antibody test. So that is interesting in itself. We will share the results of that poll as well when we upload the video. So that leaves me to thank Austin very, very much for taking time out of your busy schedule. I know you're off to homeland tomorrow, so we wish you a very, very safe trip back, and some rest and relaxation, we hope, as well. But thank you so much for doing this.
Thank you.
Yes,
Yeah,
thank you, Austin.
Bye. Bye.
There is lots of claps, we're just all on mute.
But we're big thumbs up for Austin and the team at King's. They just do absolutely fantastic work.
Thank you. Pleasure. Have a good day. Yeah, bye.
Bye, Austin. And bye, everybody. We will put everything on the website. Mariano, who's our webmaster extraordinaire, will work tonight and hopefully put everything on the website tomorrow. And Manuela will add snippets as well of this conversation that will answer all sorts of questions. And obviously other support groups, Leukemia Care and Blood Cancer UK, who've had a big role to play in the SOAP study, will also be providing some results. And as soon as we have more information, more analysis, we will share that, carry on sharing that on the website. So thank you again. Have a very nice evening. Stay safe, and see you on further Zoom meetings very soon. And if you are here for the first time also, don't forget, as a patient or as a caregiver, sign up to receive our invitations.